Hello, everyone, and welcome. Thanks for joining today's Provider Telehealth Town Hall. I'm Nikki Majewski with the Maryland Healthcare Commission, and also joining me from MHCC is Mr. Ben Steffen and David Sharp, as well as some other staff, Justine and Anna and Kelly Scott. Before we get started, I just have some general housekeeping items to go over. As you may have saw, the town hall meeting is being recorded, and we're going to put this recording, make it available on our website. In the event there's a technology failure, we will email everyone as soon as possible stating whether you should join again via the same link or a new link, or if we'll need to reschedule. Due to the number of participants on the call today, you'll remain muted until you're called upon to speak. But if we hear any background noise, we may mute you. MHCC staff will also sequence participants to make comments, starting with those who requested speaking time. And then, time permitting, we'll open up the session to other participants that would like to make comments. If that's the case, just signal to us that you would like to speak by using the raise your hand feature at the bottom, and we'll call on you. And please be sure to lower your hand once you've commented. Participants are also welcome to use the chat function. If there are too many comments to acknowledge or address during the meeting, a response will be posted on MHCC's website. And speakers are encouraged to identify themselves first by stating their name, your organization, and a little bit about what you do and the stakeholder groups you may represent. And also, thanks to those who have submitted written comments in advance. These comments will be accepted through July 31st and posted on MHCC's website. And one last thing, if you're having any technical issues with the technology, please call or email Kelly Scott. Her email contact information was sent to you yesterday or this morning, depending on when you registered. So at this time, I'll pause and I'll ask Ben Steffen and David Sharp to make some opening remarks. Ben, are you able to join and talk?
I turn on my camera and my well, first off, I want to thank the MHCC staff for putting this together. The health IT team always does this in a flawless way. And I'm sure if you haven't been to one of these before, you're going to be suitably, appropriately impressed today. I also want to thank the more than the nearly 50 people who have joined us today. The evolution of telehealth post initial surge has been impressive, as well as evolving, and we're looking forward to hearing some of our speakers today share their experiences, as well as hearing comments from the broader audience. I know all of you are very committed to the adoption of these technologies appropriately, and look forward to hearing everyone's thoughtful remarks. Thank you.
So good afternoon, everyone. I'm excited that you all were able to take time away from your busy schedule to join us today. As Ben noted, we've had prior events like this, and they tend to engage a lot of interesting thought into the mix, and we're hoping we can do that here as well again today. We are, as you all know, very passionate about advancing the work. We're going to talk a little bit about the study that's underway, and we're anxious to hear from the broader stakeholder community. And there's really no boundaries on what we're looking for you all to share. We think it's going to be useful information that will help inform the stakeholders about where we all are as a group, and it will inform some of the work that we're taking on here. So with that, I will turn this back to Nikki to get us started, and look forward to hearing the remarks from the attendees that are on the call today.
Great, thanks, David. So just to kind of reiterate what Ben and David have said, we do thank you, and your contribution has really helped create a balanced approach to the work as it relates to the telehealth study. Before we get started, we we had prepared a few slides that overview and highlight some of the progress as it relates to the telehealth study. So I'm going to step through those quickly, but first start off with just sort of the intent of what we plan to do today. We want to hear your feedback, and the intent here is to talk about telehealth and the current and future state as it relates to use of audio only and audio visual technologies. Oops, my bad. The question here, we want to hear from you about barriers, benefits, challenges, keys to success impacting access, equity, quality, and cost in a post-pandemic future. And ultimately, we hope this helps build awareness of the current and future state and will inform the study activities pertaining to the telehealth landscape in Maryland. So as I had mentioned, the study in June of last year, MHCC released an emergency request for proposal. And in September, an evaluation panel consisting of staff and external reviewers competitively selected the National Opinion Research Center, or NORC, at the University of Chicago. The law requires MHCC to develop recommendations on telehealth coverage and payment levels relative to in-person care and submit them to the Senate Finance Committee and the House Health and Government Operations Committee by December 1st of this year. To overview a bit of the activities on the horizon, based on a request from the HGO committee. This request requests MHCC to study ways to expand interstate telehealth, and the study is going to assess key considerations as it relates to insurance, interstate compacts, and licensure to inform the development of recommendations, which are due at the end of next year. And Westat was competitively awarded to conduct the study. And lastly, on this slide, it overviews key accomplishments from the current telehealth study underway. And this includes over 1,000 responses to a provider telehealth survey, interviews with Maryland consumers, an analysis of government and private payers claims, and 2 focus groups with subject matter experts in behavioral health, as well as a literature reviewing identifying many abstracts on the impact of telehealth. I also want to draw your attention at the end of this slide here. It includes a link to a dedicated web page to keep stakeholders informed about the telehealth study, and updates are posted periodically. So you can refer to the link at the bottom of this slide at a later time if you haven't already accessed the web page. Great. So I guess we'll pause here and kick off the discussion. We had several folks who have requested speaking time, and if we have additional time, we'll open it up to others. We hope to keep the comments around 10 minutes to the extent possible. So going with sort of the first person who had emailed us, Dr. Hasselfeld, if you could turn on your camera if you're able to and provide your comments. We'll look forward to hearing you.
Hi, Nikki. I'm here and on camera. If let me know how you'd like to approach it.
So if you can just state your name and your organization and a little bit about background, and then you can jump right in.
Sounds great. I am our now Senior Medical Director for Digital Health and Innovation at Johns Hopkins Medicine. I oversee our Office of Telemedicine, which is responsible for building, deploying, and maintaining all of our virtual care activity across all 4 of our Maryland hospitals, all multiple dozens of our ambulatory sites, as well as non-Maryland operations as well. I'm an internist and pediatrician by training. I care for kids and adults in primary care through one of our downtown Baltimore practices through our community physicians group. At Johns Hopkins, we've had broad and rapid uptake of telemedicine, as with many other systems. Since the pandemic began, we're approaching 1.5 million completed ambulatory visits to over 400,000 unique patients. And nearly 9 in 10 of those have been to patients with home addresses in Maryland, predominantly Maryland-based telemedicine care. We wanted to call out a few important points. First, that telehealth has been important across specialties and provider types. Two, that audio-only coverage has been a critical additional access point for those historically underserved or facing systemic inequities in accessing healthcare. And third, that the breadth and depth of expansion in virtual care has represented real investment from our hospitals, our ambulatory sites, and our delivery systems, investment in training, technology, for both providers and patients, which we believe drives reasonable conclusions around reimbursement and parity. So in the first bucket, of those nearly 1.5 million visits, over 3/4 are outside of mental and behavioral health. Nearly half are outside of mental behavioral health and primary care, general internal medicine, family practice, or general pediatrics. This is definitely a mental and behavioral health and primary care access point, and certainly our area of psychiatry has been one of our highest percentage users of telehealth, but nearly half of our virtual care activity is in other areas. To specifically scope virtual care access to any specific kind of specialty into the future, we believe removes a really important access point across all of our specialties. And yes, even ophthalmology, which had 0.2% of their total ambulatory care as telemedicine in the second half of the most recent calendar year, it's still used. And so I think the point as a provider that I make in many forums is telehealth is a tool. It's a tool that should and can be used when viewed as clinically appropriate and accessible by both provider and patient. But to regulate what kind of care should or shouldn't be inside of telehealth, to me, goes beyond kind of the potential purpose of regulation and really kind of starts to decide how medicine can be practiced between provider and patient. Similarly, we've had a lot of that care used by physicians, but over 1/3 of our telemedicine care, over 500,000 visits, was delivered by non-physicians. And that ranges from physical therapists, occupational therapists, nursing, diabetic educators, social workers, other behavioral health specialists, and speech language pathologists, genetic counselors. And so similarly, it is a tool that can be used across many provider types in addition to across different specialties. And so we believe access to coverage and then reimbursement across those specialty types is equally important. So that's bucket one, across specialties and provider types. The second, as many have seen, and we presented to the AAMC, we presented regionally and locally as well, we have a telehealth equity dashboard built up inside of our system. It's been an area of focus for us since day one. We're now on to version 2.0 in that dashboard, but it calls out 2 really important findings for us. One, telemedicine has been used more by groups on a relative basis, by groups that have faced historical inequities in access. Percent telemedicine as a percent of total care for specific groups like those insured by Medicaid, those identifying as Black or African American, is a higher percentage relative to in-person care than for those privately insured or those identifying as white or Caucasian. That data replicates data from the federal government that have been put out by HHS as well. But underneath that, so first, telemedicine, an important access point for those groups relative to in-person care versus other groups. Underneath that, our rates of audio-only use are astronomically higher for those same groups. For privately insured patients, our audio-only rate is 6% since the summer of 2020. So that's taking out all the noise of the first few months of the pandemic. So July of 2020 through April of 2022, 6% audio only. For those insured by Medicaid, 27%. 4.5 times as high. And so we see similar data as we layer on other demographic pieces, and we look at a zip code like 21205 adjacent to the Johns Hopkins Hospital, 81% Black or Black, African American, Hispanic, lower median income, using telemedicine 23% of the time, nearly 1 in 4 visits since summer of 2020, almost 40% audio only in that zip code. This is an equity issue. Maintaining that access point is a meaningful equity issue for many patient groups that we care for across our state. The last point is investment. Anyone that's engaged in healthcare over the last 2.5 years know just how much has changed. And I think similar to the CMS final rule effective last year, which really said all time on patient care is equal in how it should be reimbursed. The move from direct time to total time really reflects that time is time when it comes to engaging with patients. And certainly 1 minute by a telemedicine modality is time with patients, similar to is in person. But in addition to that, all the costs between visits is still the same. Pre-visit prep, post-visit coordination, between visit care is the same, whether it's triggered off of a telemedicine visit or an in-person visit. But lastly, there's been new costs, costs in technology, costs in education, training. Overnight, all providers and staff, as well as patients, had to relearn how to access healthcare and deliver healthcare through different forms of technology. Many will have seen with many systems in Maryland, we hosted a regional telehealth symposium where some of the focus there was showing all the work that Maryland and our Maryland systems have done in education and training and what it takes to retrain a healthcare workforce and retrain patients in how to access and consume care. All of that is meaningful investment and costs going forward. And so we believe all of that more than justifies a continued focus on ongoing parity for both video and audio only care. So those were our 3 buckets. We definitely appreciate the commission and all the work that MDH and MHA has done in helping us align to the benefit of our patients. And we'll turn it back over to you, Nikki.
So Dr. Hasselfield, we'd like to ask a few questions given the remarks you've made. And first, congratulations. It sounds like you all have done a real laudable job in terms of using technology to meet the needs of your patient population. I have a question of curiosity more than anything else, and it's how you engage consumers that are hard to reach, because a lot of times I think about consumers that are difficult to reach are oftentimes fearful of technology and sometimes distrusting of a telephone, because that doesn't feel like quite the same as sitting in front of you as the physician. How are you able to be so successful? What has been sort of like the key to engaging these hard to reach individuals and getting them to embrace telehealth?
Yeah, Dave, it's a great question. I'll go, it's ASPE, the Assistant Secretary for Planning and Education, and the Office of Health Policy in the federal government put out their data based on 2021 federal data. And our data follows that, which is that the highest rates of telehealth were among, for us, Medicaid and Black African-American individuals. For the federal data, Medicaid, Medicare, and Black and African-American individuals. Regardless, groups that most would acknowledge have faced historical difficulties in accessing care through all pre-existing modalities. We recognized up front that every step of the technology pathway, in the optimal technology pathway, can create a new barrier. And so really operating on preferred but pivot in the technology discussion of fail fast. It's okay to take branching pathways to connect with patients if the ultimate goal is to connect safely, successfully, and deliver care. So it's leveraging connectivity at the lowest common technology denominator. What's interesting in our data and our pathway, every single visit at Johns Hopkins Medicine is scheduled as video first. So there is no such thing as scheduling an audio-only visit. So when you see our data and you see that these groups are using much higher or different forms of audio-only rates, it is truly reflective of the fact that everyone was offered the opportunity to connect by video, but ended up in the pathway that allowed them to connect with their clinician successfully. And sometimes that's through video through the most optimal pathway, but often it's through video by leveraging SMS texting connectivity, knowing that patient portals can be difficult to navigate, are often written in English only. And certainly we care for patients who don't only speak English. And sometimes it's by phone, acknowledging that even if we pivot quickly, fail fast, we end up by phone, where our ultimate goal is safe, secure, and connected care to our patient through whatever modality was going to be possible. Because again, I think as a clinician, I think connecting with the patient is the most important goal to meet whatever is clinically appropriate in that form of connection. So outside of that, we're acknowledging there's a lot more work to be done. Credit to many groups around Hopkins in diversity, equity, inclusion, and community development. We're working with the Baltimore City Mayor's Office. We're working with the regional metropolitan government to think about this as a partnership, right? If ultimately technology access is a social determinant of health, if it's a piece of infrastructure that needs to be a public utility, there's a lot more work to be done there. But going out into the community to educate and train on the backbone of publicly available Wi-Fi and internet, areas that the mayor's office and others are making real investments in, that's where we're pushing next to hit the next area boundary, which comes at cost, but it's important cost to the benefit of our patients.
Okay, one last question from me, and then I don't know if others on staff have thoughts or questions. We've heard a lot about physician reluctance to really want to embrace telehealth, and it sounds like you all, that wasn't much of a challenge for you, unless there was a lot of training that was done early on to help the providers get accustomed to using a different approach, whether it be audio only or audio visual. Can you speak to any of the challenges and the pathway to success that you all have unearthed?
Yeah, absolutely. I think a couple of core points there. In March of 2021, 1 year into the pandemic, we sent out a survey to just our own clinicians who had completed a telehealth visit at that time. That was over 3,600 clinicians, most of whom are Maryland based. We got over 1,300 responses just on our internal survey alone, asking a number of questions, including how much telehealth do you want to do going forward? And I think what came out of that is that we are definitely more on the early adoption portion in both populations, patient and provider, in how to engage in clinical care through a new pathway. And when we're on an early adoption pathway, we're going to have many who say 0%. To me, as a patient, going into the office and being touched is what it means to be cared for by a clinician, and similarly to a provider. But for many others, we saw 100%. I actually only want to do telehealth going forward. And for many patients, in fact, we have a number of subjective comments from patients in some of the presentations that we have. And one of them that I use often is, I would prefer all visits to be virtual and come in if necessary. It's been the most transformational way to access healthcare. It's efficient and personal. We have 100,000 patient surveys that overlie comments like that. And so I think for us, the key has been to make it easy, make it available, do not force, allow it to be a tool to be chosen by providers and patients when they both feel it's clinically appropriate for the specific type of clinical question that's facing that unique patient-provider partnership, and find ways to ensure that in the 0% bucket, we're not changing the availability for the 0% provider and patient, meaning I only want to be in the practice, and also making ways to make it easy and accessible for the 100% patient and provider, those that only want to be virtual. We're going to live in this continuum of care like we always have, except now it's hospital, emergency room, urgent care, clinic. We're adding in virtual, and patients will access care across the continuum. We need to find those who want to be on the 100% side and ensure we're building for them, but also build for everyone else in between. Make it easy, don't force, make the resources available, and listen. Make sure we're continually improving.
Thank you, Dr. Hessfield. Ben, your comment?
Thank you, Dr. Hasselfeld. I did have a question that kind of ask you to take on the role of the technical assistance expert. As you probably know, there have been multiple state funding efforts over the last 18 months to make broadband more widely available. Has Hopkins thought of a kind of a natural experiment to look at where broadband, state or other entities have expanded broadband, and what the uptake is in those communities where that has become available? And secondly, have you been able to test any ideas that patients that started out on audio only migrated to audio video? Any sort of systematic data that your team has been able to put together? I appreciate the need during the pandemic to have audio only. I think pre-pandemic, we all would have been startled if we'd been told that audio only was going to be defined as telehealth. But the pandemic taught us a lot of things, but I think ultimately the goal would be, when appropriate, to have full audio video access for every Marylander. So any thoughts on testing being helpful to the state in what the impact is when broadband is expanded?
Yeah, a couple of thoughts there. We have our use of audio only as a percentage of total telemedicine. As I mentioned, we've visualized many ways, and that includes visualizing at the zip code level. For the local governments, we have mapped that for Baltimore City to the census tract level, even more granular, to be able to ensure that we can show an output of investment in broadband is its impact on different forms of health. And I mean that in its broadest sense. Here, we mean health, medical health, but also other areas will be interested in economic health, job development, wage growth. Others will be interested in educational growth, remote learning and educational opportunities. We feel proud that we can provide that level of granularity to our public partners in thinking about some of those both inputs, where might investment be most impactful, and outputs, where has investment made a difference. So I would just say that we're focused on partnering with that kind of data to understand how changes in broadband accessibility may change any one of these measures that we would all view as important for broader health for our Marylanders. And think it's an important way to visualize this kind of data geographically across our state. I think it's important, though, to just call out that I would love it if everyone could be fully, I'll use the term, digitally educated, accessible, and literate in all that means tomorrow. But that means not just broadband access. It does nothing to have broadband access if I also don't have the device to write on it. But then it also does nothing if I don't have the education to understand things that we feel are very basic. Many of us do who live in technology. What is Wi-Fi? How do I access public Wi-Fi? What is a browser? What is a patient portal? What does it mean to go down these pathways of technology? Since January 1st of this year, 2022, our private pay audio only rate is 5%. Our Medicaid audio only rate is 25%. Now 5 times the commercial rate. It's not changing, and it's not going to change quickly. Regardless of accessibility to internet, it's going to take these other areas of investment in digital literacy on top of access to internet to fully close that gap. It's going to be a 5 to 10 year journey, and I think it's important for us to view it across that timeline.
Ben, I think you're muted.
I just want to say that Dr. Hausfeld didn't know I was asking that question, but very good and complete, thorough answer. Thank you.
Thank you. Any other questions for Dr. Hasselfield? And we could open that up to the larger audience if for a moment. Let's see if we get any hands or comments here. And for the staff, if you all see any hands, if you could alert us as we go through the list. I'm not seeing any, so with that, we thank you again, Dr. Hasselfield, for your comments, timely and relevant, and we'll move on to Dr. Crockett. Dr. Crockett, are you able to come off mute and turn your camera on?
I am, thank you.
Welcome. Thank you for joining us today.
Well, it's a pleasure to be here, and I was marking off things I was going to say as Dr. Hasselfeld was speaking, so I will try to be efficient with my time here. I did want to reiterate that the infrastructure necessary to do telehealth equitably, and to do telehealth in high quality is there. It's something that we need to discuss, that we need to allow for. We have been able to reach, in answer to one of your questions, we have been able to reach some of those hard, or to engage some of those hard to reach around improving things, improving our resources and our technical assistance available for improving digital literacy. We've also done a lot of work around making sure that access to devices is not the barrier. But as Dr. Hasselfeld said, it's not whether I have the device, it's not whether I have the broadband, it's not just that. We need to know how to use it. At Kennedy Krieger, I guess I could have started with this, right? At Kennedy Krieger, we are primarily a specialty children's hospital. So we don't see as many adults, we don't see as many of elderly, et cetera. But for the families that we see and the patients that we see, we've really been able to make sure for most situations, devices is not the barrier, but there's still so much work to do with getting people used to receiving care in this way from a digital literacy standpoint. Other things that I was hoping to kind of highlight, we were doing telehealth early on. We were doing telehealth before the pandemic. So we were able to switch over pretty quickly, and we were able to provide a lot of the similar training that was discussed earlier. So I think we had a lot more buy-in for a lot of our providers. We still have reluctant providers. We still have providers where it's just not, it's not what they're interested in. It's not the care that they choose to provide. And we have patients in the same way. So we're really looking at telehealth in some situations as the primary way of delivering care, but typically we're looking at it more in terms of an augmented way of delivering care. We've been able to successfully reach those that are living in provider shortage areas, Western Maryland, Eastern Shore, Southern Maryland, et cetera, as well as outside the state. But you know, those areas may have situations where they're relying more on the primary care. Those are going to fall probably more to the behavioral health side of things, but not exclusively. I mean, we're still having, we still have care delivered over telehealth in a lot of other specialties, so speech therapy, physical therapy, et cetera. So the reach with telehealth is well beyond behavioral health. I think it's very important to make sure that those other specialty groups are informing the commission of the usefulness of telehealth within that, so that we're not looking at it just within a behavioral health, within the behavioral health umbrella. And I think another thing that perhaps we may be able to do is share some of the discipline-specific findings that we have, that we've been able to find and publish as it relates to the use of telehealth comparable to in-person services. So I'm going to pause there. Again, I know a lot of things already mentioned with Dr. Hasselfeld, but I'll take any questions. Otherwise, I'll give my time.
So I thank you very much, Dr. Crockett. But the first question that comes to mind is, you mentioned that telehealth is used to augment care delivery. And I was wondering if you could expand upon that a little bit. And I say that going into this because one of the comments Dr. Hasselfeld made was that telehealth, it starts out as audiovisual and then it could evolve to just being audio only. When you think about augmenting care delivery, is the options presented during scheduling? Is it more discussed? Yeah, where's the discussion point come in? Do they go from audio visual and then to audio only? How is that pathway and that process delineated for your patients?
So I will certainly give a little bit more information in terms of augmenting care. It's not really going to be from an audio only perspective. I think a lot of our colleagues across the state are doing much more audio services than we are at Kennedy Krieger. So I probably am not the best to speak to that. We do a very small amount of audio only services. But certainly it is a vital need for the patients who need it, because technology issues, et cetera, that arise. We of course, like Hopkins, we strive for the audio visual as our go-to, and then we adjust as we need to. Our augmenting care really looks more in terms of like our hybrid services. So we may have patients who begin with in-person and then do a combination of telehealth follow-up as well as in-person follow-up when appropriate. So that's the degree of augmenting care that we're using, or in person with particular specialties, but then able to receive other specialties through telehealth.
Okay, and then thank you for that response. Then the next question centers around the use of it for providing therapies. You mentioned that that you all use telehealth a lot for the therapeutic aspect of it. Could you elaborate a bit more about that and any kind of reactions that you could share with us from the patient population to using it in therapy?
Absolutely, and I'm sure that we would be able to share some of our patient and provider experience that really cuts across the different disciplines at Kennedy Krieger to give you some more quantitative as well as qualitative perspectives on that. But again, keeping in mind the population of children that Kennedy Krieger work with, there are certainly going to be the situations where in-person care, hands-on, are what's going to be needed. But there is a rich amount of follow-up that can be conducted in the patient's home using telehealth, in the patient's home where the family is having to navigate how this child is able to independently access their house, right? So when we can actually get in the home using telehealth and have eyes on there and coach the caregiver on the appropriate use of the treatment plan, for example, make modifications via telehealth. I mean, that's such a rich experience that really you can't duplicate that when the patient is in person, right? So having that ability to actually have eyes on in a patient's home, where again, whether it's a mobility issue, whether it's a speech issue, whether it's a behavioral issue, that has been one of the richest aspects of telehealth from a provider perspective. And from families' perspectives as well. I mean, we've had so many families say to us, I'm so glad you're actually able to see how my child is in the home environment, right? I can't tell you how many times patients come to Kennedy and the parent kind of throws their hands up and says, well, he's just being perfect today, right? And so, I mean, that ability, to get in the family's home is just something that's been so vital.
And has the provider population who delivers these therapy services, have they provided you all with any sort of anecdotal data by saying, we find that children of a certain age aren't nearly as good as telehealth patients as someone who might be years older. Have you run into some of this anecdotal data that says it's great for this age group, but it may not be so good for that age group?
Yeah, I think the challenge there is, yes, of course we have, right? But it's very hard, as Dr. Hasselfeld discussed. It's, I think over time we are going to learn that maybe there are diagnoses that just maybe, or treatments that just maybe don't translate as well over telehealth. But a lot of times what we're looking at is maybe it's provider preference, right? Maybe it's provider comfort, maybe it's patient comfort, maybe it's patient preference. And I think in some of those situations, I like how Dr. Hassfeld talked about the buckets, right? And in the 0 bucket, I don't ever want to do telehealth. Like, are those situations because it's not right for your child? Are those situations because you don't feel comfortable doing it? You don't understand how to navigate it? I just think I could give you all of those examples. I just think we're too early in the process to be able to speak globally on a particular age child working with telehealth, not, et cetera. I'm a psychologist and I work with very young children. I have colleagues who say, how can you work with a 4-year-old, who has behavior problems via telehealth? Well, it depends on the degree it depends on what we're doing in therapy. If I'm doing a lot of parent coaching, right, and I'm providing parent-based education, then that is very rich for telehealth, right? So it's really just, I would love to be able to give you an overall answer. I just think we're too early in the process. And right now we haven't yet been able to determine, is it really because of the particular disorder or the particular condition, or is it because any of those other things that we've talked about, access, literacy, comfort, et cetera?
Okay, and then one last question I have, and then we'll open it up to others. If you were able to go back to the start of the pandemic and do it over again, what would you say as a psychologist delivering telehealth you would like to see different?
Oh my goodness. I wish we were very fortunate to be able to get some devices out to families. I wish we could have gotten them out to families sooner, before they had some probably frustrating situations with trying to connect and then just not being able to, and feeling as if care wasn't possible to them in this time where we were at stay-at-home orders, et cetera. So I wish we would have been able to kind of get things sooner to families. I mean, we're talking about, we got things in May, right? So I mean, that was May 2020, but I just know that March and April and May were very, very scary times for a lot of families whose children have very complex needs. And we were somewhat limited in how we were able to reach them. I wish, like anything, that the infrastructure was, that the access was equitable. I mean, I wish that to this day. And I think we need not look just like in the remote areas or think about the rural areas where access is limited. We just have to look next door, right around downtown Baltimore. So I think those are probably the things that I would change if I could.
Yeah, no, very good points. So any comments or questions from staff here? Okay, hearing none, I think we'll move on to Dr. Prabaker. Hopefully I'm saying your name correctly, sir.
Thank you. So let me begin by just thanking MHCC for this opportunity to comment on this very important topic. I am Dr. Prabhakar. I serve as the Chief of Medical Staff and Medical Director for Outpatient Services here at Shepherd Pratt. We do offer a lot of mental health care services as well as special education services. In fact, we are the largest not-for-profit organization here in the country. I also have the great fortune to serve on Maryland Hospital Association's Telehealth Advisory Committee. So nationally and regionally, as we just learned from our learned colleagues, we have seen a significant inflection towards telehealth utilization overall. This has improved access. It has brought many more under the umbrella of much needed care. What I would do is I would use my time here to make a strong case for continuing telehealth and audio-only services from what I can see from the work we do here at Shepherd Pratt. So let me start with the patient story. It probably gets to a couple questions that have been already asked pertaining to that experience that a patient or a family or sometimes providers are looking forward to when it comes to telehealth or audio only. So this patient I'm going to describe is a 37-year-old gentleman diagnosed with schizophrenia. He has been in our care since June 2019. Prior to the implementation of telehealth specific to his treatment location, given the severe and persistent nature of his illness, he was often non-adherent, not attending appointments, not following treatment recommendations, missing several clinical appointments, which was a constant risk when it comes to acute destabilization, him being in an ER, him being admitted to a hospital. Since we implemented virtual health at the program he's currently serving, he's currently being served at, the treatment team has been able to keep the patient in regular treatment with the help of telehealth as well as telephonic services, helping him adhere to clinical recommendations for the most part. What are those recommendations that we are able to help foster through these telephonic conversations and telehealth? These include safety planning for risk behaviors, including harm to others, aggressive thoughts, assessment of suicidal behaviors, and ongoing treatment planning. He has been assisted person periodically by a provider team as necessitated by his clinical presentation and need for monitoring the ongoing treatment response. This is where that previous discussion kind of comes in, how we bring both things together in person with telehealth, in ways augmenting overall treatment rather than picking and choosing one or the other. So the patient prefers telephonic sessions as he feels most comfortable with it, given his unique living situation in a group home. This is a patient who lives in one of the residential facilities here in Maryland. With the help of these necessary tools, specifically our ability to provide treatment appropriate to telehealth and telephonic visits, he has been stable in the community setting, not requiring inpatient hospitalization or visits to hospital ED. I'm certain many of us probably can look back and find similar stories of individuals who have benefited and continue to benefit from these telephonic and telehealth approaches. Now at a macro level, away from the patient, over the last 3 months of the previous fiscal year, and I'm giving the most recent kind of estimates only, so this is April through June. Out of our 4 largest outpatient service group locations, primarily public mental health care system, both adults and children, telephonic visits accounted for about 20% of the total visits that we serve in those locations. 70% were telehealth. So we are still doing predominantly telehealth, telephonic visits out of for those locations, again addressing the needs of the populations that we already heard about that continue to struggle when it comes to access to care and parity for services. Now, these are the visits that are catering to patients in a similar scenario to the patient I mentioned before, along with providing access to quality ongoing care to families with young children, single parent households, low income families, and to individuals who just can't keep up required number or regular appointments due to number of reasons like transportation or their own employment. It's very difficult for folks to get in a car and travel 45 minutes for a 30-minute appointment on a regular interval. But with telehealth, with telephonic, all of that is now possible and plausible. So to summarize, I would just request the stakeholders to continue to rely on this, on the clinical judgment of providers and clinical teams. I think this is a point that was made earlier, to help utilize telehealth and telephonic services and help inform payment parity for these services. Ultimately, this is all towards, indicated an appropriate level of care, improving access, and fostering good clinical outcomes. Thank you.
Thank you, Dr. Prabhakar. Have you, question for you, have you encountered situations where patients or their families are reluctant to use the technology out of concerns for privacy?
So early on, as we were kind of moving towards telephonic and telehealth service or virtual health, as we said, we did need a lot of education, how it facilitated care rather than being a barrier to care. Some residential settings are also posing a challenge, continuing to this day. If people live in group home kind of settings, then obviously there are things for us to take care of in terms of providing appropriate level of confidentiality of or anonymity for them in that particular setting. So yes, patient education, family education is really important in terms of us facilitating care through telephonic or telehealth. The tool itself is not enough.
And so the patient education strikes me as could be an arduous task to try to work through. Have you all found the secret sauce to that, or is there really no one size fits all, and privacy issues, when their privacy concerns remain, and patients won't succumb or be interested in using telehealth?
So this is where flexibility is very important. Treatment engagement with the team, the primary team is very important. Some constancy in terms of the people they're dealing with on the clinical interface side of things is also important. I think what we have found is, and there is no secret sauce to this, but having those individualized conversations with these patients, appreciating that this is a challenge. That just because we are bringing technology to the table is in itself is not going to be sufficient. I think that's the first step towards that. Making sure that as we are providing education and trainings to our own clinical staff and support staff, we're also taking care of what are the issues that are on the minds of our parents and our patients. We have had many scenarios where a patient felt comfortable going to their car with their child and having a telephonic or a telehealth visit from their car compared to a household where they didn't feel comfortable because of the topics they wanted to discuss. So the treatment was, again, very pertinent to that specific child, the specific mom or dad. And these are the kinds of tools and these are the kinds of things we were discussing with our clinical teams, where what are the safer ways of providing telehealth, telephonic consults, and what are the things that we can safely do with these two modalities. It has served us very well. However, not every clinical visit can be safely handled on a telephonic visit, and not everything that can be discussed on telephone should be discussed on a telephone only visit. Sometimes we need to lay eyes on our patients. So what I have learned from my experience here through the pandemic is that if we empower our clinical teams with that information, give them all the tools that they need to have in order to facilitate this appropriate level of care, they do that safely. So that has been one of those lessons out of this pandemic too, that going back to everything that we do in medicine, which is trusting clinical decision making to that clinical team appropriate to their licensure, their discipline, their training, that has served us very well with telehealth also.
Okay, very good. So one follow-up question, it relates to the clinical team. You mentioned about training and acclimation to technology. I'm curious to know if the reluctance is sort of in pockets, or do you find that there are providers who just generally don't feel comfortable using it and probably are not going to?
So here at our organization, what I have found is that reluctance bucket has shrunk pretty much every single day since implementation, especially during the pandemic. What we have learned is a lot of folks who prior to the pandemic were slow to come to the table when it comes to virtual health, they were eager to kind of learn and get on board. Now, what on the clinical side, what the provider groups or the clinical teams have seen is in many of our clinical programs, our non-adherence rates were very high. Our no-show rates used to linger around 30%, 35% in some of the challenging clinical diagnostic entities, or with some of the challenging kind of societal and other issues that we deal with pertaining to social determinants of health. So if a patient population was struggling with that, we used to see a lot of no-shows and late cancellations, those kinds of things. So the provider group has seen, and the clinical teams have seen great improvement in that. Now those rates have shrunk from being 30% to less than 10%. So that has been a boon in terms of making sure that their patients are in regular treatment. That has helped quite a bit. So personally, I'm not seeing those kind of huge pockets of reluctance that we used to see prior to the pandemic. And I must say this has brought some flexibility to the work-life schedule of our provider and clinical teams also. So that's another kind of benefit out of this whole effort, that they can do a lot more things without having to worry about traveling up and down different clinical locations to be present at different wherever the patient care needs are.
Very good points. Thank you, sir. Our executive director has a question for you. And Ben, I think you're muted.
Always. I'll learn how to turn on the mute within the next 2 years. Thank you, Dr. Prabhakar. I did have a question about the protocols on you mentioned the 37-year-old patient who was a patient and migrated to telehealth. What are your protocols for bringing new patients in, does that automatically begin with a choice, or do you have requirements that you begin with face-to-face assessments? Tell us a little bit more about this. And then just a second follow-on question. I know Shepherd Pratt has been heavily involved in working with the state on dealing with challenges for hard to place patients, placements for adolescents. Can expanded use of telehealth offer any opportunities for eliminating some of these overstays and those sorts of challenges that have dogged the state for years, but are seemingly growing in even greater difficulty?
Yes, let me take the second question first. I think this is where we can truly make a difference. What I have observed is if virtual option is not even available, whether it's a zip code or a rural area or even in urban settings, what happens is patients and families unfortunately are forced in a situation that unless there is truly a crisis, they are not going to step into a care environment. Because sometimes, unfortunately, that care environment is the closest hospital's emergency room. And that's not a place where most families feel comfortable taking their child in, or their adult in, or their loved one in, or somebody walking themselves into an episode of care. What we have seen have happened over the course of this pandemic, but also is a true opportunity for us, is if this access is provided to those individuals before the difficult state gets to a crisis state in the close comfort of their own home, we have an opportunity to avoid that visit to the ED or an acute hospitalization or the crisis in itself. When we were doing the early stages of pandemic, we caught a lot of crisis states from developing as we saw treatment disruptions in different zip codes, different parts of the state. We were able to come in, do a virtual appointment, bridge the gap to the next safest available appointment for that patient. So this is a true opportunity for us in terms of ensuring that we are a bit more preemptive and proactive compared to being reactive, or where we are always just looking for placement options for the kids or adults who are already in an ED. Going back to the first question, so yes, from a policy procedure standpoint, a new patient can be seen safely in an in-person setting or in a fully telehealth visit. We don't do telephonic only new patient evaluations as a policy here. Now, when we are doing those intakes, our admission access coordinators, they evaluate the patient care needs, and at that point, they direct whether or not this would be a safe first patient interview to be had on audiovisual telehealth, or they may need to come in person. So that's kind of a decision that gets made at that point. But from an availability standpoint, both of those options are available for our patients.
Thank you.
Thank you very much, Dr. Prabhakar. So let's move on and welcome Dr. Booker from MedStar. If you're able to turn on your camera and speak, that would be great.
Yeah, thank you, David, and thank you for having me here. So I'm Ethan Booker. I'm the Chief Medical Officer for Telehealth for MedStar Health. I'm an emergency physician. I continue to practice in emergency departments. And in that role have had the opportunity to take care of patients who come to the emergency department, and began my own telehealth journey in looking at opportunities to improve the care and efficiency and equity delivered in our telehealth in our hospitals, but also examining why it is that patients arrive in the emergency department. Many of my colleagues have talked about emergency departments and emergency department avoidance as one of the benefits of telehealth and earlier interventions through access. In my role of Chief Medical Officer, I'm also a researcher around telehealth with an AHRQ study that looks at a social technical systems framework of telehealth. That is the interaction between systems, people, and technologies, and how those things interact to allow success or failure in systems that require regulation, human interfaces with technology. And in that role have been able to collaborate with others to develop a data set of approximately 1 million patients pursuing care with 4.1 million encounters across our own health system, Stanford and Intermountain, and with that wealth of data, have data very similar to what Dr. Hasselfeld described in terms of the distribution of telehealth, demonstration that telehealth is an economic substitute, does not induce demand, and that there are variations in socioeconomic factors that are really very important in terms of access to care. The primary one being that across the board, remote care is used by every demographic area that we examined in all of the zip codes and different socioeconomic features, but the modalities differ, with audio only being considerably more utilized by older patients, African-American Black patients, and patients who have other limitations to care, such as transportation. Again, in the role of Chief Medical Officer for Telehealth, I've been able to contribute to the NCQA's Digital Health Equity Framework, and I would direct the Commission to the white paper that resulted from that work to describe some of what we think will be a reasonable framework for describing what is important in digital health equity as we think about how we wish to move forward in the state of Maryland in delivering care. The experience of our providers is very similar to what Dr. Hasselfeld said, and I won't go over it exactly, except to say that we have a very similar volume and a very similar distribution of care and face some of the same challenges. As I hear your questions regarding reluctance on the part of patients, reluctance on the part of providers, the importance of training, the importance of support, these are all things that we attempt to address in the challenges of delivering care. I want to make sure that I'm thoughtful of everyone else's time here. And the last thing that I will say is my role actually is also within the MedStar Institute for Innovation, meaning that I am charged by our health system not to look only at telehealth as a reasonable substitute for what we have traditionally done, but as an opportunity to improve the ways in which we deliver care. And that means that we require clarity about the way forward in terms of the landscape for delivering that care across multiple states, and the flexibility to use the modalities that are appropriate to the care of the patient when they need it. I'll end with an example of what I mean by that. So as Brian pointed out, we have lots of non-physician providers and lots of non-primary care or behavioral health providers. And I would point to our movement disorder specialists at Georgetown as an example, in which we have nurse practitioners working with our neurologists to provide care to Parkinson's patients throughout the region. I don't know that I've heard more satisfied patients and patients' families than Parkinson's patients who don't have to navigate an hour and a half in the car to come to Georgetown to see their Parkinson's specialist, or Parkinson's specialists, nurse practitioners, or physical therapists who can evaluate the Parkinson's patient in their home and actually understand what their capabilities and safety is in the setting where it matters the most and not in their office. They still come to Georgetown because they need imaging, they need testing, they need to understand what's relevant in the physical exam. But they also use the phone, they use text, they use remote patient monitoring, and they use video. And that all of the above modality approach allows the application of that best knowledge to the patient's need where they need it. And I think it's a good demonstration that flexibility in modalities allows that time, as Brian pointed out, the time, the knowledge, the complexity to be applied to the patient when and where they need it. I'm happy to take questions, but I'm also really curious to hear from my colleagues. Thank you.
Dr. Booker, thank you very much for that enlightening set of comments. Question that comes to mind is that you've mentioned a situation where the use of telehealth, whether it's audiovisual or audio only, is been extremely successful, and Parkinson's patient was the area you noted. Would you say that your learning experiences through the pandemic and following have indicated where you would say this is not an appropriate use for either telehealth or audio only?
I think it's an excellent question, and my own perspective about this is I think a lot about the acute care space. I am an emergency physician, and so the acute care space comes to mind most readily. And I think you would get broad agreement that one wouldn't wish to manage an acute heart attack by video in the patient's home. Having said that, would I rather have that patient reach out to me in the middle of the night when they have some discomfort that they're a little bit concerned about that may turn out to be heartburn, but may turn out to be heart attack, and then have the opportunity for me to direct them to the right site for care. I would much rather have them have access than think it's heartburn and roll back over and go back to sleep. So I think there are certainly places where telehealth is not an appropriate destination for care. But I think even in the highest acuity settings, there may be a role for multiple modalities to identify patients, whether that's RPM and you're identifying them as they decompensate through physiologic monitoring, or access through phone and video to then direct them to the right sites for care. So I can't think of a clinical circumstance in which I wouldn't want to have all of the tools. I wouldn't necessarily want to use the wrong tool in the wrong circumstance, but the availability of the tools is an important structure for how we deliver care.
And my last question, you mentioned the availability of tools. What has been your largest challenge around that, and how have you all seek to solve it?
So I think that some portion of challenge for MedStar, for Hopkins, for all of us who exist in a densely populated area that comes across multiple states is multi-state licensing for our providers. That is certainly one of the challenges and continues to be a challenge. I would also suggest that the patient's access to technology and the ability to use it does present challenges. Those are challenges that can be overcome. For instance, we make sure that we have multiple modalities of communication, not just audio, video, or audio, but multiple ways of doing audio, video, so that we can minimize, for instance, packet size for video to limit broadband. So, but I think for us, multi-state licensing, unpredictability in what the regulatory and reimbursement framework and landscape will be, especially over multiple jurisdictions in the federal environment. And then patients' access to reliable technology and the ability to use it to communicate with us.
Very good. Thank you, sir, for your remarks. They were very informative. Are there questions from the staff at MHCC? Okay. Hearing none, we will travel on to Dr. Thurman. Welcome, Dr. Thurman. Are you able to turn your camera on and unmute?
Yeah, you can't hear me or see me?
Now I can, yes.
Oh, okay, great. Thank you. I just want to thank the MHCC for inviting me to talk, and my colleagues who went before me, who covered very thoroughly many of the things I had on my list of things to discuss. So I thought I had a little opening with talking about my role as an ER doctor, but Dr. Booker stole that one right before I could speak. But I will start there because I think it's important. So my role at LifeBridge Health started in emergency medicine. I'm an ER doctor, still clinically active. And then now I'm the system CMIO. I've been in that role for about 5 years, 6 years, and also the medical director for our telehealth programs. And I wanted to start with the ER because, like Dr. Booker and many others, I've seen firsthand what happens when patients don't have access to healthcare, and when they don't have access to even video by telehealth. And the first thing that they can do, often on a landline, is call 911. So they have access to a landline telephone, and the only way they can access care through that is by dialing 911. So we see a tremendous burden on our ERs and a tremendous disservice to our patients, and a tremendous financial burden, frankly, on the state and on the payers related to ER visits that are probably inappropriate. And by one analysis, we estimated that between 10 and 15% of our ER visits could have been handled by telemedicine, and instead they're there and tele and all that, and we're treating them at a very high cost to all the people who pay for it. So I wanted to start really with the cost, because I think that's an important thing to identify, and certainly a lot of why we're discussing this, because it's perceived as more expensive or more costly, or more care is given in telehealth. And the truth is, I don't believe that. From our experience with hundreds of thousands of video visits, I actually haven't counted our audio visits, but we're up there too. Our experience with telehealth started about 4 or 5 years ago when we were trying to get providers to embrace it. And the truth is the providers were very reluctant to embrace it for a variety of reasons, but one of which is it was new and cumbersome for them. And I want to dispel the myth about increased usage. They spend as much time, probably more time, with patients, engaged with patients over telehealth than they do in-person visits. They're not able to see twice as many people in a day in their ambulatory clinics because they're doing telehealth. They're not, doubling their billing by any stretch. They're filling the same slots with video visits most of the time, as opposed to in-person visits. So to the provider back in the day, it was more convenient for them to just, tell the patient they have to come in. It was an inconvenience to the provider. It was equivalent care, but it was not something that they were motivated to do because it was, more convenient to ask the patient to come in. Obviously, as many people have mentioned before me, there's a lot of barriers for patients. I'll highlight a couple that are different. We talked about all the socioeconomic barriers and caregiver barriers. We brushed on the age barrier, but essentially, age is a barrier both for technology with video, which is kind of why I think audio only has a place there, but also for transportation and mobility. And so we reach out, a lot of our telehealth is to elderly patients who otherwise wouldn't receive the care until it was way down the progression of disease state, and they were in dire straits, and they're often admitted in that case. And then the last one I wanted to touch on is geography. There's deserts of care like other things, and there's patients further away who really are out of our catchment and don't have a close facility. And so we can reach way beyond the normal geography with telehealth. Let me see what else I wanted to mention. So, we think that ultimately, in terms of the cost, essentially, we think that there's a huge cost savings involved because of the lower ED visits. We also employ another type of telehealth, and the studies have shown here that there's about a 3 to 4% ED avoidance of those patients that we take care of by telehealth. So you can look at it from one side and say 10 to 15% of the ED patients could have been taken care of by telehealth, or on the other side, you can look at of all the telehealth we do, 3 or 4% we estimate by a couple different methods would have otherwise gone to the ED of the telehealth bucket we do. So either way you slice it, it really does avoid a higher level of care that's not necessary, and it's not good for people. It's not just about the cost, of course, but to allow a disease state to progress until someone needs to dial 911 or needs to be admitted, obviously is a terrible reality for people who don't have access to care. So in terms of our adoption curve, I mentioned that providers were reluctant at first for many reasons, but one of which was it just was inconvenient and they just required people to come in. The reason why we went from tens of thousands of visits a year to several hundred thousand video visits a year is because of the patient demand. So I think that you've heard from doctors, and there's no patients on this call, but our doctors came running to us to set them up with telemedicine because their patient panels, and obviously it was during COVID when many patients were afraid to come in person, but still it's persisted. About 10 or 12% of their patient panels are demanding that they keep their telemedicine options open. So patients are really driving, in my opinion, a lot of the demand for telehealth and the adoption of telehealth in our system anyways. And so I think the voice of the patients and is one also to appreciate. And for all the reasons that we've all discussed, patients are demanding that this be a modality that they can be seen. The last thing I was going to touch on is the audio only. It is, when I think about the telehealth that we do, traditional telehealth, it's a small fraction of our work, a single-digit percentage of our work, but an important part for those who don't have the technology or the ability to do video. But it has a place, obviously, with behavioral health. It's a fantastic modality for that, but in many other cases, like Dr. Booker said, starting with an audio and then taking it from there ultimately lets the patient be triaged, if you will, to the most appropriate point of care. So we offer video first in our services of telehealth, just like Dr. Hasselfeld said about Johns Hopkins. But in a sense, we also offer audio first in that we call by audio and a nurse every single patient that's discharged from our ED. And we're trying to start doing that for our discharged patients inpatient. We reach them by either a phone call or a SMS texting system that we use to keep in touch and to check in on them. And then if there's issues, we escalate those to video. So when we offer video in some of our programs, it's video first, and then we do audio if it's needed. In this instance, we start with audio, a quick check-in, make sure things are okay, and those are then escalated to video if there's an issue. And the vast majority of those video escalations never result in a next escalation to a return ED visit. They're often escalated from video to an urgent care visit or to a primary care visit, and that's fine because it's appropriate. But for the ED in particular, we avoid, like I mentioned, about 4% of those video visits or those ED discharges would have resulted in return ED visits if not for our telemedicine program. And the last thing about audio only, which I think is an interesting observation that we've made, it hasn't been mentioned, and I think it's important, is that in some ways, removing the video actually provides for a better visit. I know that sounds counterintuitive, and so a couple examples for psychiatric visits, but even for other visits where the patient might feel uncomfortable being completely honest about what's going on, or if they're feeling certain ways. For some obvious reasons, I guess audio allows them to kind of disclose more. We've also found that in our patient population, when we've kind of exit interviewed some of our patients who refused the video and preferred audio, it wasn't because they always didn't have the capability to do video. Sometimes they didn't, they were embarrassed about their living conditions or, their surroundings, or something that they felt was uncomfortable, essentially. And so these are patients that would have declined the video visit had we not offered an audio option. And so there's definitely a place for audio across the spectrum, with behavioral health being an obvious starting point, but in many other ways that my colleagues have mentioned. But there's also some unique instances where the quality of a visit's higher with audio than with video. So I'll close with that, and I'm happy to answer any questions if they arise.
Thank you, Dr. Thurman. I do have one clarification question, if you could. We've heard both sides of the spectrum when it comes to the number of visits that can be seen in person versus telehealth. And we've heard mixed reviews. Some providers actually say they're able to see more patients in a day via telehealth. And you suggested, I seem to recall you saying that it doesn't really create opportunities to see more patients. It's just a different modality. Could you explain or clarify that point a little bit?
Yeah, so I think there are some newer modalities, which I'm actually very excited about, because they would allow, in this era of a real shortage of providers and healthcare workers in general, it would allow a leveraging of their time. So asynchronous telehealth is an example of an area that we're exploring, and I'm very excited about, that does allow providers to multiply, let's say, their time because of the nature of asynchronous visits. But for the most part, we found that, and the reason why I made that statement is that, so suppose there's a little bit of efficiency because you don't have to turn over the room or whatever, but the time the providers spend on the phone or on the video with the patient is roughly equivalent to the time they would spend in the room with the patient. So a very well-run practice where the provider, and I'm talking about ambulatory medicine now, where they would hop from room to room to room because they have good staff and a well-oiled machine. They are spending equivalent time with the patients in that practice as they would on video. And so the video doesn't really enhance or leverage their time. certainly their time and their medical decision making is what they're there for. And just like, you know, an attorney charges the same amount, whether they're on the phone with you or you're in their office. The physician is spending the same 8 hours a day, seeing the same 40 patients, whether it's video or telemedicine, video or in person. In our experience, maybe they see 44 patients versus 42 patients because there's a 10% efficiency or something, but not a great increase in the volume that they can see, because they're asking the same questions, sometimes more, because they really want to make sure that they're covering all the bases. So that's been our experience with that. I can't hear you, I'm sorry.
Thank you, Dr. Thurman, for those comments. So we will move on in the interest of time. We have about 5 minutes left for the meeting. What we will ask folks to do is, if you can stick around an extra 10 minutes, we'd like to get the last two speakers, Dr. Krako and Kim Wireman, give a chance to hear what they have to say. So why don't we invite Ms. Wireman to open up this last segment of questions and comments.
Thanks very much. I'll try to be brief. Everyone's been so comprehensive. I'm Kim Wireman from Powell Recovery Center. We're a 300-bed residential treatment facility for SUD and dual recovery clients. We only treat public health clients, and we've been using telehealth since April of 2020. We were able to field telehealth very quickly, and it allowed us to navigate the pandemic. But we have used it incredibly effectively to date by allowing flexible delivery of not only psychiatric but medical services, follow-up psychiatric visit, follow-up dosing visit, in some cases first dosing visit when a client comes in late, if a prescriber is on call. It's allowed us to have our dual recovery clients. About 50% of our clients who present for treatment are dual recovery clients. Our clients are typically fentanyl dependent for 3 or 4 years, heroin dependent for 15 years prior. They're homeless with no resources. And so when they come, they're in great need, and we try to deliver those crisis services as quickly as possible. Telehealth has allowed us to do that with tremendous effectiveness. We have been able to have clients who present for addictions treatment see our psychiatrist same day, second day, or third day for those low baseline clients who need that kind of immediate response. Additionally, we can apply through telehealth nursing care that would be onerous to deliver face-to-face for that client for the first 3 days. And then surprisingly, as our clients go through residential treatment, what we find is those clients who are re-entering the community, many of our clients have never worked. And so our goal as they go through residential treatment is to acquire a job. We find that as they're re-engaging in community, that it's critical for them for attendants to have some flexibility and some telehealth service in the evening. Most are working during the day. If they're on shift work, then early in the morning, in order to be able for them to have a reasonable schedule, because of course our clients, no one owns a car. They're either walking or they're on public transportation. So we're very much in favor of audiovisual telehealth and audio only as a permanent service delivery. And we would strongly advocate for the same rate as in-person services. Lastly, our provider association completed a statewide survey of clients in all levels of care in June 2020. We had an N of 400 with over 85% of clients expressing satisfaction with their services. We followed that up again in February with a statewide survey with an N of 197. We had over 80% of clients surveyed expressing satisfaction with telehealth. That includes audio only. I'll stop now for brevity's sake. Thank you very much for the opportunity to share that information with you.
And thank you, Ms. Wireman. One question before we move on, and that is, If you had to do this over again, or if you could make one wish for a change, what would you suggest as it relates to the use of telehealth audio or audio visual?
I would provide parity between telehealth and audio services. So critical for some of our clients. Audio is so critical for some of our clients. But I would also simply allow the provider to determine the amount of telehealth. I think the state, for good reasons, has sought to regulate that a little more than they need to. We are providing now telehealth where it makes sense within the COMAR guidelines, as well as face-to-face for our residential treatment. For outpatient treatment, we see a significant, although we don't have measurements yet, that's going to be part of our next survey. The engagement in IOP and outpatient has increased significantly due to telehealth.
Okay, thank you, Ms. Wireman. Let's go on to our last presenter, Dr. Krockow. Are you able to unmute and turn your camera on?
Yep, I'm right here. Good afternoon, everybody. Thank you again for the opportunity to speak with you. I am an emergency medicine physician by training, like several of my colleagues before me. It sounds like there's a pattern. I am the vice president for the Access Center and Telehealth within the University of Maryland Medical System. Also, during the course of the pandemic, I was the operations section chief for University of Maryland's COVID-19 Unified Command. And the reason that I share that with you is after the comprehensive presentations that you heard from the speakers before me, I think the best thing that I can do is just tell this group a story. I'm going to tell you a story, and the story starts in March of 2020, at the start of the pandemic. Now, like the other organizations represented on this call, we had telehealth before COVID-19 came along, but in full disclosure, the University of Maryland didn't have a lot of it. We had some of it, but COVID-19 and the whole pandemic response was a metaphorical injection of steroids into our telehealth architecture. At that time, in March of 2020, we were using third-party vendors that enabled telehealth. We know those vendors. They're commonly spoken about on the news and by others. And what we identified was an opportunity to standardize our telehealth platform. And as we did that, we decided that the standardized platform needed to be stable in all circumstances, not just for those people who had robust Wi-Fi connectivity, internet connectivity. It had to be incredibly easy to use. And so our destination was that we've built out an easy button. There are no apps, there are no web browsers. Look, my parents, my mother and father are both 85 years old. They have a smartphone. I can describe for you in exquisite detail how facile they are with that smartphone. They don't know anything about downloading apps. They don't know anything about using the web browser on the smartphone, but they know how to text me and they know how to call me. And so our platform that has been created is functional in those areas where connectivity is not as strong. It works as just audio only, and it works off of a platform similar to SMS texting. What we found during the course of the pandemic response and our build out of new telehealth architecture is it's not just physicians using it, it's nurse practitioners, physician assistants, social workers, physical therapists, occupational therapists, and we take surveys on the patients that receive these, and 95% of our patients have rated the telehealth service that we deliver as a 4 or a 5 on a scale of 1 to 5, 4 or 5 as favorable or very favorable. We've delivered the care from Garrett County in the Western Panhandle to the easternmost reaches of the Eastern Shore. We've gone into other states, Pennsylvania, West Virginia, Delaware, Virginia, etc. And our most common patient is a Medicare patient. Secondly, is a Medicaid patient. So this is not just for commercial payers. It's not just for Blue Cross Blue Shield. It is the full spectrum mix. And as I said, Medicare patients were the most common utilizers of our telehealth platform. It has reduced by 10 to 15% our cancellation and no-show rates. What we've also found is that we've been able to keep care local. We've been able to expand the offering of specialty and subspecialty care. And I will just mention that many of you will likely recall about 9 months ago, as we were preparing for the Omicron surge, the conventional wisdom was that the pediatric population was going to get disproportionately hit with Omicron for various reasons, on top of RSV, on top of flu. And in discussions with the Maryland Department of Health, there was a concern that we did not have enough pediatric beds in the state of Maryland. And speaking strictly from the University of Maryland Medical System's perspective, our strategy, which exists today, is standing up the architecture to deliver virtual pediatric support in any part of the state for those who needed us. Now, I'm going to tell you one other little story. It's an extra story. It's a bonus story. I'm not just a healthcare provider, I'm also a patient. On February 4th, while skiing down a very icy Black Diamond slope, I sustained an injury. I tore my ACL, strained my MCL, and had a tibial plateau impact fracture. On March 17th, they took me to the OR. When you're my age and you sustain an ACL injury, 6 weeks, no weight bearing. I don't know how many people are listening to my voice who have gone through an ACL repair before, but for 6 weeks, no weight bearing. It was much easier for me to see my orthopedic surgeon through telemedicine rather than making the trip to the orthopedic office. And in subsequent telemedicine visits, they were able to look at my flexion and extension and my wound and assess whether or not I was progressing in the manner that they wanted. So in the interest of time, I'll just conclude and say that the University of Maryland Medical System is incredibly supportive of maintaining and actually leaning into telehealth architecture. We have many different designs on the drawing board in the blueprint. And there was a question asked at the earliest outset of this meeting. I forget who asked the question, but it was around overcoming the challenges of telehealth adoption. I will tell you exactly what was relayed to me on several different instances. At least within the University of Maryland Medical System, there is nothing more for us to sell on telehealth. COVID-19 sold telehealth for us. Any reluctance that existed prior to the pandemic has largely evaporated for us. I yield the balance of my time. Thanks, everyone.
Dr. Krako, thank you very much for your time today, and quite an impressive story. I think very touching to hear your own personal experience, and I think many would find it very warming of your ability to use telehealth to guide through that care delivery process. We could ask lots of questions about technology, and we might want to do that offline as a follow-up. It sounds like you all have done some great work there in developing a platform that's balanced and that works effectively. So congratulations on that. We are over by about 10 minutes, so we'll push through the last couple of slides in the wrap up to try to keep everyone close to the committed time. Nikki, can I turn this back to you for a moment?
Sure. Thanks again, everyone. As David mentioned, we will accept additional written comments if you'd like to submit them by the 21st of this month. We have some questions. We were going to open it up if there was time, but there was so much great discussion, we are unable to, but feel free to respond to these or any other thoughts you have to share and submit them to Christine Karyanopoulos. Her email is listed on this slide and in the email that was sent prior. And then, of course, we'll follow up with the summary of today and the video recording, as well as everyone else's written comments after the July 21st due date. So probably look out for an email around the week of July 25th. And in the meantime, if you have any other comments or questions, feel free to email me or Christine. And thanks again so much for your time and all this great discussion.
So I would like to invite our executive director, who's been listening and participating in this discussion, to make some final comments.
My comments are very brief. Again, thank you for all the participants who stayed throughout. I do note that Dr. Booker has put the link to the NCQA report in the chat. So before you drop off, you might want to copy that down if you're inclined to look at it. And again, The MHCC staff, great job on keeping this well organized and pretty much on schedule. We had the additional time was well worth the investment in my mind, and I hope everyone else agrees. So thank you, everyone, and have a good day.
Thanks, everyone. Be well, and we appreciate so much your input. Have a good day.